Welcome to the deep dive, everyone. Today we are unpacking something that I feel like is just completely glossed over in standard healthcare.
Yeah, it really is.
That's right. I mean, we are looking at the source material on the structural collapse of postmenopausal reproductive anatomy. Over 50% of postmenopausal women experience this literal physical deflation that leaves vital, highly innervated tissues completely exposed to the elements.
Exposed and incredibly vulnerable.
Exactly.
Huh?
Yet for decades, medicine has essentially just, shrugged this off as a cosmetic reality of getting older. But our mission today is to look at the actual biological cascade of labial volume loss, unpack the mechanics of why this happens, and explore how it triggers this massive domino effect of friction, environmental sensitivity, and chronic pain.
Right, and to understand that physical deflation, we really have to start with the biological driver behind the entire pelvic architecture, which is estrogen.
Estrogen.
Yeah. We tend to think of estrogen purely as a reproductive hormone, for having babies.
No.
But in the context of the vulva and vagina, it acts as this foundational maintenance hormone.
Okay.
It dictates tissue thickness, elasticity, blood flow, and, crucially, the local production of collagen.
And the data on what happens when that maintenance hormone drops off is just staggering. I mean, in just the first 5 years after menopause, a woman can lose up to 30% of her skin's collagen. 30%.
It's massive. It really is a cliff.
Yeah. We hear about that kind of structural loss all the time when it comes to, the face or the neck.
Oh, absolutely.
But the exact same process is ravaging the pelvic region, and it's treated like a completely different thing.
Well, the medical term for this specific geographic loss is lipoatrophy. And we are talking specifically about the labia majora, so the thick outer lips of the vulva.
Right.
In a premenopausal state, the labia majora are rich in fat cells, which are called adipocytes, and they're supported by these dense dermal ridges of collagen. But as estrogen plummets, fibroblast cells, which are
Fibroblasts are
they are essentially the microscopic construction workers that build the collagen.
Got it. Go.
So they go dormant. The natural hyaluronic acid in the dermis degrades, and those fat cells actually shrink down or are completely reabsorbed by the body.
Okay, let's unpack this because I want people to visualize it. It's like a delicate package losing its bubble wrap.
That's a perfect way to describe it.
Yeah, because the labia majora are supposed to be this thick, protective outer layer. But when the estrogen drops, the padding just vanishes.
It vanishes, and the histological evidence, like when you look at the tissue under a microscope, it shows the dermal ridges literally flattening out.
Wow.
So the tissue transitions from being plump and resilient and well-vascularized to becoming papery, thin, and just incredibly fragile.
Like tissue paper.
Exactly like tissue paper. And because those outer lips serve as the primary protective barrier for the entire vulval region, their deflation is the catalyst for a massive functional failure.
So the anatomical architecture just collapses. The outer lips shrink, which means the inner structures are suddenly thrust out into the open. And the clinical literature refers to this as the unveiling effect, right?
Yes, the unveiling effect, because the labia majora are anatomically designed to meet in the middle and serve as a closure mechanism.
Okay.
So as they lose volume and flatten, the underlying fascia, which is the deep connective tissue matrix that anchors the skin to the muscle layer, it loses its tensile strength. The outer lips sort of retract inward and backward.
So wait, are we saying the anatomy is actually shifting, or is it just that the surrounding landscape is getting smaller?
Well, if we connect this to the bigger picture, it is absolutely both.
Both. Okay.
Yeah, the fat pads shrink, which eliminates the physical bulk, but the structural fascia also weakens and gives way, so it alters the spatial relationship of the organs. Functionally, the labia majora are a facial analog.
Oh, meaning they act like the face.
Exactly.
Yeah.
They deflate in the exact same mechanical way the cheeks or the under eye areas hollow out as we age.
I see.
But when your cheeks deflate, the primary consequence is visual. When the labia majora deflate, they leave highly sensitive, highly innervated mucosal tissues entirely defenseless.
Defenseless against the elements. Because the structures that were supposed to be tucked safely away inside that closure mechanism are now protruding past it. We're talking about the labia minora, so the inner lips, the clitoral hood, and the urethral meatus, which is the actual physical opening to the urethra.
Right, and we also have to include the vestibule, which is that delicate tissue immediately surrounding the vaginal opening itself.
Oh, right, yeah.
All of these structures have an incredibly high concentration of nerve endings. And furthermore, the clitoral hood, which is essentially a prepuce meant to glide over the clitoris, it undergoes its own fibrotic changes due to the estrogen loss.
So it's not just exposed, it's actually changing structurally, too.
Yes.
Uh,
Because it loses elasticity and is now exposed to external trauma, it can contract and adhere to the adjacent tissue. It can actually fuse and bury the clitoral glands, leading to a profound loss of sexual sensation and function.
oh, wow. So the protective hood shrinks and essentially traps the very thing it's supposed to protect.
Exactly.
And because this entire landscape of delicate anatomy is now unveiled, it initiates this brutal domino effect. And the first domino seems to be mechanical trauma. Before, these structures were guarded, but now the labia minora and the vestibule are subjected to constant, unrelenting friction.
Yes, and keep in mind, the epithelial layer, so the outermost protective layer of cells on these tissues, is already thinning out because of the systemic lack of estrogen.
Right, so it's thinner to begin with.
Exactly. So when you take a thinned, fragile mucosal membrane and expose it to the mechanical friction of just walking or sitting or wearing tight clothing like leggings, the result is micro tears, severe inflammation, and a chronic sensation of rawness.
It seems like that friction alone would be agonizing, honestly.
Yeah.
But the sources dive heavily into environmental sensitivity too, specifically a phenomenon termed winter vagina, which, I'm not going to lie, it sounds like an internet myth, but it is a heavily documented clinical reality.
Oh, it is very real. And the underlying physics of it are quite simple. The tissues of the vestibule and the inner lips are mucosal, so they are meant to be kept in a humid, internally regulated environment.
Like the inside of your mouth.
Exactly like the inside of your mouth.
Mm-hmm.
So when the labia majora retract, these mucosal tissues are exposed to ambient dry air.
Wow.
And during winter, when humidity drops, the dry air physically pulls moisture out of the already compromised tissue. So women experience stinging, chafing, and a sensation of cold drafts reaching highly innervated tissues that were previously insulated.
I mean, feeling cold drafts on those specific tissues, that has to be so startling and uncomfortable.
It is incredibly distressing for patients.
So if the root cause of that stinging is a lack of moisture, we have to look at the next domino in the cascade, which is secondary dryness. The area essentially loses its ability to lubricate itself from the outside.
Right. The labia majora house dense networks of sebaceous and sweat glands, and these glands produce sebum and local secretions that naturally reduce friction, maintain moisture, and provide a protective lipid barrier over the skin. When the physical volume of the labia majora diminishes, the gland density and activity crash alongside it.
So the tissue is literally incapable of holding onto water, the lipid barrier is broken, and the area is being rubbed raw by clothing.
Yes,
But the chemistry of the region also flips completely upside down, right?
it does. A normal, healthy premenopausal vulval and vaginal environment is highly acidic, usually sitting around a pH of 4.5.
Okay, so quite acidic.
Very. And that acidity is the primary defense mechanism against infection. It's maintained by lactobacilli, which are the beneficial bacteria.
Good bacteria.
Right. And lactobacillus survive by feeding on glycogen, a type of sugar produced by the epithelial cells. But the crucial detail here is that estrogen is the biological signal that tells those cells to produce glycogen in the first place.
Oh, I see the chain reaction here. Estrogen drops, so the cellular signal stops, the glycogen disappears, and the healthy lactobacilli just starve.
They completely starve. And without the lactobacilli pumping out lactic acid, the pH of the entire region skyrockets.
It becomes alkaline.
Yes. A more alkaline environment immediately alters the local microbiome. The protective bacteria die off, creating a vacuum that opportunistic pathogens rapidly fill.
So the bad bugs move in.
Exactly. Coliforms, which are bacteria typically found in the gastrointestinal tract, and Staphylococci, which live on the external skin, migrate and overgrow in this newly hospitable alkaline environment. The result is chronic, low-grade inflammation and dysbiosis.
Okay, here's where it gets really interesting. Because if we take that microbial shift, right, the gut and skin bacteria taking over, and we combine it with the mechanical exposure we talked about earlier, it perfectly explains the massive spike in urinary tract infections in postmenopausal women. The opening of the urethra has lost its physical bumper guard.
Precisely. The urethromeatus is left protruding and rubbing directly against underwear fabrics. So that mechanical friction introduces bacteria into the urethra. And simultaneously, the local tissue is thinner, riddled with micro tears, and the acidic shield that would normally neutralize those bacteria is just gone. So the pathogens have a direct, unshielded highway right into the bladder.
That is just wild to think about. So a woman might spend years taking rounds and rounds of antibiotics for what she assumes is a fundamentally failing bladder or a compromised immune system, when in reality, the physical shield that kept bacteria away from her urethra is simply gone.
Right, it's missing.
That completely changes how we should be looking at recurrent UTIs.
It really does. And grounding these symptoms in the mechanical and histological reality validates an immense amount of suffering. In clinical settings, patients frequently describe a fire crotch sensation.
A fire crotch sensation.
Yes, a relentless external rawness and burning. And historically, this was often dismissed as a vague chronic pain syndrome or psychological distress.
Which is just maddening.
It is. The biological reality is that declining estrogen has dismantled the tissue barrier functions, stripped the lubrication, altered the pH, and left the nerves completely exposed to physical trauma.
So if the problem is a structural collapse leading to mechanical and chemical chaos, just slathering on a topical moisturizer isn't going to fix the underlying architecture.
No, it won't. I mean, over-the-counter hyaluronic acid-based moisturizers and water-based lubricants provide critical immediate relief. They coat the exposed nerve endings, temporarily soothe the stinging, and provide necessary glide during intimacy.
So they're helpful, but
But they do not induce cellular change. They cannot prompt dormant fibroblasts to build collagen, and they cannot replace the missing fat pads. They are symptom management, not structural restoration.
so to actually change the tissue behavior, you have to reintroduce the biological signal that went missing, which points directly to localized hormonal therapy.
Yes. Low-dose vaginal estrogen, which can be delivered via creams, small tablets, or slow-release rings, is the foundational medical intervention here. It delivers the hormone directly to the vaginal and vulval epithelium.
And people are always worried about the systemic effects of hormones, right? Like breast cancer risks and all that.
Right, but because the dosage is profoundly low and localized to the pelvic tissue, systemic absorption into the bloodstream is negligible, making it highly safe for the vast majority of patients. It wakes the tissue back up.
Oh, that's great.
It thickens the epithelial layer, restores the glycogen production, feeds the lactobacilli, and drops the pH back into that protective acidic zone.
Okay, but even if the local estrogen restores the skin quality and fixes the pH, it doesn't spontaneously generate new fat cells, right?
No.
Like the labia majora could still be severely deflated, meaning the structural bubble wrap is still missing and the inner tissues are still mechanically exposed.
That is the exact limitation, and it has driven a massive evolution in functional gynecology, specifically toward structural restoration procedures. If the mechanical dysfunction is caused by missing physical volume, the most direct medical solution is to physically replace that volume.
Okay, so we're talking about fillers here.
Yes, we
Yeah.
are seeing extensive clinical data on the use of specialized dermal fillers in the vulva.
Yeah, the sources specifically highlight cross-linked hyaluronic acid fillers like the Cereal Plus and Alaclay. But these aren't just generic facial fillers being used off-label, right? They're formulated specifically for this tissue.
Correct. Hyaluronic acid, or HA, is a naturally occurring molecule in the body known for its extraordinary ability to bind and hold on to water. When we talk about cross-linked HA, it means the molecules have been chemically bound together to form a dense 3D lattice structure.
Sort of like a net.
Exactly, like a net. And this cross-linking prevents the body's natural enzymes from breaking the filler down immediately, allowing it to act as a durable physical scaffold. Clinicians inject these specialized high-density fillers directly into the deflated labia majora.
Reinflated the cushion.
Exactly.
And the clinical outcomes show that this physical plumping forces the anatomical architecture back into its correct spatial arrangement.
So the outer lips close over the vestibule again.
Yes. By restoring the sheer mass of the labia majora, the physical gap is closed. The filler effectively tucks the highly sensitive labia minora, the clitoris, and the urethral meatus safely back inside.
Oh, wow.
And the clinical trials for these specific HA formulations demonstrate a drastic reduction in mechanical friction because the clothing is once again resting against the padded outer lips, not the delicate mucosal tissue.
That makes perfect sense.
Furthermore, by closing the environment, the tissues can retain their natural moisture, essentially curing the secondary evaporative dryness. Wait, okay. If the goal is restoring lost fat volume, can you just use actual fat? Because I know fat grafting is super common in breast reconstruction or facial surgery, so is it being applied to the labia majora?
Absolutely. Fat grafting, or autologous fat transfer, is a highly effective long-term solution for lipoatrophy.
Oh, okay.
A surgeon harvests the patient's own fat via gentle liposuction, typically from the abdomen or inner thighs, purifies it, and then strategically injects it into the labia majora.
Well, since it's the patient's own biological material, there's no risk of rejection, right?
Exactly.
But how does the body keep that injected fat alive in a new location? Does it just kind of float there?
No, the success of fat grafting relies on vascularization. When the purified fat cells are injected, they are placed in tiny microdroplets throughout the tissue layers.
Okay.
This allows the body's existing blood vessels to rapidly grow into the newly transferred fat, providing it with oxygen and nutrients.
Oh, so it hooks it up to the blood supply.
Yes, exactly. Once that blood supply is established, the fat behaves like normal living tissue. It provides a soft, completely natural plumpness that lasts for years, accomplishing the exact same mechanical shielding as the HA fillers, but with permanent tissue integration.
That is fascinating. But for patients looking for structural remodeling without injectables or surgery, the research heavily features energy-based devices. We're looking at CO2 lasers like the Mona Lisa Touch or radiofrequency devices like Forma V and Morpheus 8V.
Yes. Energy-based devices operate on the principle of controlled thermal damage. Rather than adding external volume, these devices deliver precise columns of heat or radiofrequency energy deep into the dermal layers of the vulva and vagina.
Right.
This controlled microtrauma triggers the body's natural wound healing cascade.
So the brief, intense heat essentially tricks the immune system into rushing fresh blood flow, macrophages, and growth factors to the area.
Exactly. That healing cascade forces those dormant fibroblasts to wake up and start mass-producing new collagen and elastin fibers, which is a process called neocollagenesis.
Neocollagenesis.
Right. And over a series of treatments, the tissue remodels itself from the inside out, becoming significantly thicker, more elastic, and better vascularized. It is a powerful, non-hormonal, non-surgical mechanism for reversing the cellular atrophy.
So what does this all mean? For the listener at home who might be experiencing this cascade of symptoms and feeling incredibly isolated, the takeaway is twofold. First, chronic pelvic pain, burning, and recurrent infections are not just a normal, acceptable part of aging that you have to silently endure.
No, absolutely not.
And second, seeking to restore your physical anatomy is a legitimate medical intervention.
What's fascinating here is the complete paradigm shift taking place in how the medical establishment views these treatments.
Yeah.
For years, procedures like labial fillers, fat grafting, or radiofrequency were casually dismissed and categorized strictly under aesthetic gynecology.
Like a vanity project.
Exactly, a vanity project. Women were made to feel vain or frivolous for even inquiring about them. But the clinical data we've reviewed today definitively proves that their primary benefit is functional.
Functional.
Yes. Restoring the outer volume cures the secondary dryness, it physically halts the friction, and it shields the urethra to prevent UTIs. It is the functional restoration of a highly complex protective organ system.
We are literally talking about rebuilding the body's natural armor. So to recap the biological journey, as systemic estrogen drops during menopause, the pelvic region loses collagen, and the protective fat pads in the labia majora shrink and reabsorb. As those outer lips deflate and retract inward, the delicate inner tissues, so the clitoris, the inner lips, the urethra, and the vestibule, are unveiled. And this mechanical exposure leads to brutal friction, extreme sensitivity to environmental drafts, and a total collapse of the acidic microbiome.
Right.
However, by combining local estrogen to fix the cellular chemistry and structurally rebuilding the lost volume through specialized fillers, fat grafting, or thermal energy, we can close the physical barrier and actually cure the underlying dysfunction.
The mechanics of the problem and the solutions are very clear. However, it was vital to remind listeners that any new symptoms of pelvic pain, persistent burning, or unusual bleeding require direct evaluation by a healthcare provider.
Oh, definitely.
While volume loss is incredibly common, those symptoms can also indicate other serious pathologies, such as lichen sclerosis, undiagnosed infections, or precancerous cellular changes. A proper clinical evaluation is always the mandatory first step.
Do not attempt to self-diagnose through the pain. Get a professional evaluation to map out exactly what is happening to your specific anatomy.
And this raises an important question. In modern medicine, we treat the structural loss of bone density in menopausal women as a standard, expected issue requiring proactive systemic care. We treat the loss of facial collagen with a multi-billion-dollar preventative industry. If labial volume loss predictably leads to such measurable, devastating functional decline like chronic pain, recurrent urinary tract infections, and the complete disruption of sexual function, why is the structural maintenance of the pelvic region not a routine preventative part of women's healthcare long before the protective shield is entirely lost?
That is the exact question we should all be bringing to our next doctor's appointment. Why wait for the structural padding to completely collapse before we attempt to protect the vital anatomy inside?
Something to think about.